Welcome to the JOMA Preventative Health Podcast, hosted by the Jewish Orthodox Women's Medical Association. We provide you with up-to-date information on health topics geared towards the Orthodox Jewish community. This podcast content is provided for informational purposes only and is not intended as medical advice or as a substitute for the medical advice of a physician.
Welcome to the Jewish Orthodox Women's Medical Association, or JOMA podcast. I'm your host, Elisa Minkin. I'm a general pediatrician and proud JOMA member. And tonight I'm really honored and really excited to be here today with Dr. Andrea Zimmerman. First of all, if there's a topic you want to hear, if you want to be interviewed, if you know someone you want to hear being interviewed, you have a comment on our podcast, please reach out to us at health, HEALTH, at joma.org. We want to hear from you. Andrea Zimmerman, OD, FAAO, Doctor of Optometry and Low Vision Specialist at the Lighthouse Guild, obtained a BA in biology from New York University, graduating Magna Cum Laude with a Phi Beta Kappa distinction. She received her Doctor of Optometry degree from SUNY College of Optometry and completed further educational training at the Lighthouse Guild for treatment of individuals with low vision. Dr. Zimmerman is a fellow of the American Academy of Optometry and is an Adjunct Assistant Clinical Professor to SUNY College of Optometry. Dr. Zimmerman is also published in professional journals for work in low vision optometry. Welcome, Dr. Zimmerman. Thank you so much for joining me tonight.
Thank you, Dr. Minkin. Thank you for having me. It's my pleasure to be here.
You know, we got actually two requests. This is a first for me, that I got two separate people emailing me, please cover vision-related topics. And I have not even begun to touch this, so I can't put it all on your shoulders. This is going to have to be the first of more than one talk, please. Can't cover it all today, but let's get started. I want to first start by explaining the terms, the difference between optometrist, optician, and ophthalmologist, because they all sound kind of the same.
They do, and many people do get them confused. Sometimes we hear obstetrician in there too, but obviously that's another topic. But so an optician, my husband's an optician. Opticians make glasses and they fit you for glasses. Optometrists and ophthalmologists are both eye care professionals that evaluate vision, evaluate eye health, diagnose and treat eye disease. Ophthalmologists are medical doctors. They've gone to medical school and they've done a 3-year residency or maybe a fellowship specializing in maybe glaucoma or retina, and they do surgery. Optometrists go to optometry school, also a 4-year bout of education after college, and specialize many times in functional vision, which are binocular vision disorders or vision rehabilitation, which is what I do at Lighthouse Guild.
Fantastic. That's a great explanation. Okay, I want to start, because I'm a pediatrician. I'm going to move to adults, we really have to, but I want to start with the babies.
Yes,
when do you think a baby should first have a vision screening?
So it's really, I'm so happy that you asked me to do this, because I think we all know this, but we don't realize it. So, you know, in the delivery room, the pediatrician on call is actually doing a vision screening. They're looking to see if the infant has a red reflex. They're looking for pupillary response. They're looking for blink response. They're evaluating the overall health of the eye, you know, the external anatomy, not really getting into nitty gritty. But so that's the first screening when a mother gives birth. That's being done for the infant. And then as the infant grows and sees you, Dr. Minkin, or another pediatrician, the infant is still being screened by the pediatrician to see, again, still pupillary response, blink response, is there a ptosis, overall appearance, red reflex, and there is something called PediaVision, which you might be familiar with.
We use it.
Which is almost in adults instances, we use an autorefractor. It's kind of like an autorefractor where you get an idea of the infant's prescription or what the prescription might be by taking a picture of the infant. And these are all screening methods. And again, in, up to about the age of maybe 3, these are usually okay with exceptions. And the exceptions obviously are if an infant is born prematurely, there's always a risk of retinopathy of prematurity. If there's a history in the family of eye disease, I have a family that comes to see me and they have aniridia. And each child has some form of aniridia. So those children were, because it's an autosomal dominant type of condition. So there are certain conditions that do run in families, and those infants are usually referred to a pediatric ophthalmologist right away to see what the entire story is. Again, if you see a white pupil, that's a sign that something's not right. Maybe there's a cataract or retinal detachment, or God forbid, retinoblastoma, which is cancer of the retina. So there are certain conditions definitely where screenings are not enough in infants. And then usually by the age of 3, definitely by the age of 3, children should have some form of full eye examination.
Mm. Right, because I did want you to point to the difference between screening, which is not really diagnostic, and testing.
Right, absolutely. So obviously screening versus evaluation is very different. Screening, we're just doing a basic run through, not even a run through, but just a basic evaluation of overall, appearance and function. You're not really doing much evaluating in terms of ocular health or function, or does this child need, is the child very nearsighted or very farsighted or have a high astigmatism?
What other screenings would, because we mentioned the PD vision, what other screenings would you see, say, in a regular pediatrician's office?
So obviously, many pediatricians use eye charts, which have to be put at a certain distance away from the child. Hopefully, the child is being occluded one eye at a time. So in pediatricians' offices, you might see eye charts that have to be located a certain distance from a child, and you really have to make sure that each eye is being occluded, so that you can get a proper evaluation or even a proper screening of one eye at a time. Because if both eyes are open, you might be missing the fact that the child can't see out of one eye. And children are notorious for kind of doing this, right? So, you really have to make sure that one eye is covered at a time. Many times people also use vectograms for screening. I don't know if you've seen those. Those are machines where in school they use them a lot. And the child has to put their eye into a machine and be able to look at different slides to check the acuity. The problem with those machines is sometimes the lenses are blurry and the child can't see. So many times I get children referred to me saying that they can't see, and the problem is the machine was dirty. So they weren't getting an accurate description of how the child sees.
Right. I mean, screening is just, it may have a false positive, it may have a false negative. One thing I do want to talk about is amblyopia and the importance of picking that up.
Yes, so that's a very good point. Thank you for bringing that up. So many times, if a child has poor vision in one eye, that's either due to an eye turn or to a very poor, to a great prescription, either very nearsighted or very farsighted, or a high astigmatism, or even a high astigmatism in both eyes, actually, or very farsighted or nearsighted in both eyes. The neurological system of the vision pathway does not have the ability to properly grow and properly develop. And so the eye or eyes end up becoming lazy. They can't function. And as we know, children have a lot of neuroplasticity. They're allowed, their brains have the ability to, their brains have the ability to adapt or change, once they're given the right path, so to speak. So if we catch a child before the age of 7 that's very nearsighted or very farsighted in one eye or both eyes, and we correct that condition, or has an eye turn, and we correct that condition, then the child can grow and have a normal, healthy eye that is able to see. It's very interesting because I see adults many times that have poor vision in their good eye, and they have a lazy eye. And the lazy eye still develops a little bit, even in their 60s and 70s. There's still some neuroplasticity going on, which is very interesting, not
I
to
didn't
the
know that.
extent that children have it.
Right.
It's very interesting, but it's really not to the extent that children have it.
So I want to really talk about a whole bunch of different topics, and what they all have in common is that you can have a vision problem in one eye and what that could mean. So I have a list here. I have ptosis, which means a droopy eyelid, cataract, clouding of the eye, turning in or turning out of an eye if it's one eye,
Right.
all of those things.
You're talking about that list that you had sent me, correct?
Yeah.
Or...
So all of these things have in common that if you have a decreasing vision in one eye, what can happen?
So right. So if you do have decreased vision in one eye, then you develop a lazy eye, where again the visual pathway does not have the right way to develop, so that information from the eye is getting to the brain. So the eye becomes lazy, whether it be from ptosis, where part of the lid is covering the eye, whether it be from a high prescription, whether it be from an eye turn, whether it be from a cataract, or anything obstructing vision in one eye can cause that eye to become lazy or amblyopic. And again, only by removing that obstruction or removing whatever is impeding the vision in that eye can you allow the eye to develop properly. And that can only really happen with any great efficiency before the age of 7 or 8.
Because of that neuroplasticity, that's much greater.
That's exactly right. That's exactly right.
Do you want to talk for a few minutes about patching and how that works?
Sure. So again, that's been used for many, many years and is still very effective with children. So if one eye is lazy or amblyopic, again, due to an eye turn or a high prescription, what we do is we cover the good eye, not the whole day. What's been found is maybe 2 hours a day while doing some type of task. So, not reading because the eye is still not up to functioning properly, but maybe coloring or doing a puzzle or some type of functional task where the eye has to concentrate, it has to work. We're forcing the eye to work with the proper prescription, hopefully. And also, if you have a turned eye, if you're patching, the eye becomes straight. So you're still forcing it to work in the proper sense. And once you do that every day or every other day, the eye becomes able to function in a proper way. It learns how to function. It learns how to see.
Right. You don't ignore the eye. You don't
ignore the eye any longer. That's right.
What if the child doesn't let you patch them?
So that's a big problem with many children. Yeah. And I'm not a pediatric specialist, so I can't tell you all the different ways, but bribery is always a good thing. Mm-hmm. And again, if it's just for a minimal amount of time, if it's 2 hours when they're home, not in school, nobody can see them, I think most parents are pretty effective at being able to help their children with this. And they do have different types of patches now that have cartoons on them and that are pretty. And, so children sometimes, they want to get that patch. It prompts them to want to do that.
Right, they have cool patterns and stuff. But for, say, a child who might really have sensory issues or something, I do believe there's drops.
So there are drops as well that are mydriatic drops or like atropine, which paralyzes the accommodation in the good seeing eye. So that, again, the eye that is worse at seeing, the lazy eye, has to function better. It has to work harder. The problem with the drops is that the drops last a really long time.
Right.
So atropine, especially cyclopentolate, not as long, but still, even one drop of cyclopentolate lasts for about 4 hours.
Right. It's like when you go to the eye doctor and you can't see forever after.
Right. It's very, that's right. It's very interesting, actually. What they're starting to do is they're using very small percentages of atropine, because, again, for the vision training optometrists, for the vision therapy optometrists, and even, for myself that does not do vision training, many times we see people that accommodate, they focus very, very hard, and that actually causes spasm in their focusing mechanism, so that they have eye strain and headaches. So many times what we're doing now is we're taking very small percentages of atropine drops and just paralyzing the accommodation just a little bit, not so much, so that the eyes can work properly, but not overwork, so to speak.
That is interesting. That is really interesting.
So that's a new modality.
Yes. So I also want to talk about what happens when you pick up low vision. We're still on the kids. We're never going to leave the kids because
that's okay. That's okay. There's a lot to talk about. There is, and and so so I do work for Lighthouse Guild, and it's for people that don't know, it's a not-for-profit agency that deals with people, children, adults that are visually impaired, and we help them to make the most of their vision and help them to function in school and work, at home, walking, whatever they need to do. And for infants, we do see infants, again, for those high-risk infants, for those infants that have ROP, retinopathy of prematurity, or have had some type of ocular disease that's been diagnosed already, up to 90, 100 years old, obviously. But for the infants and the children, once we see them and we evaluate them, we can register them with an agency. It's called the New York State Commission for the Blind. And usually, to be registered for this agency, you do have to be considered what's called legally blind. But children, we definitely make allowances for. We really want to try and get children into this agency, involved with this agency, because the agency is wonderful in making sure that kids get what they need in school, whether it be large print or a tablet, in order to be able to read on a tablet, which has very black letters on a very white background, or magnifiers or electronic magnifiers that make the print much larger, so that the child does not have to struggle their whole life and can succeed, and not have the vision impairment be the cause of what's keeping them back in school.
Right. We skipped over all the kids who just need glasses, and we're talking about at this point, the kid who's, I think the definition of legally blind is if correction cannot exceed 2200 with glasses.
In the best corrected eye.
Right.
So that does not mean a child that's nearsighted and sees 2200 without glasses.
Right.
So it means that there's a physical anomaly in the eye itself preventing the vision from being good. So kids that that need glasses, it's very interesting for infants and for children that are not that have trouble speaking. We have ways of measuring the vision. We have certain charts that are called teller visual acuity charts, which are really interesting. It's a big board, and there are black and white stripes on one side of the board, and there's nothing on the other side of the board. And the black and white stripes become narrower and narrower, and are measured in cycles per degree. And they correspond to visual acuity. So if we hold up this board in front of an infant normally will just look at a target. They don't want to look at a blank piece of paper. So they look at the target, and we can shift the board to see where is the infant looking, until the stripes become so thin and narrow that you don't see the stripes any longer. And that's how we can get an idea of what the infant or the child's acuity is. So that's one way of measuring acuity. Another way is we have something called lighthouse symbols, which again, sometimes children don't know the names, or they don't know this is a square or a circle or a house. And we put a puzzle in front of them, and we show them the different shapes, and they can point to the puzzle what the shape is. Again, another way, another way of evaluating vision in a maybe a very young child, or a child that doesn't have the ability to speak. So we can evaluate their vision sometimes in a much better sense. And again, the PediaVision, the PediaVision test, it's a great test, but if a child accommodates, if a child is very farsighted and they accommodate, you actually end up getting not a correct reading. So if you use a retinoscope, a retinoscopy on a child in real space, you get a much better reading of what kind of prescription does this child need. So,
but the PediaVision is just for screening.
Correct. But sometimes the screen, no, obviously because it's a screening, it can be off. So that's why.
Off meaning you would think what? What would it?
So if a child is very farsighted and can focus through that farsightedness, say they have a prescription of, I'm just giving numbers, but if they have a prescription of +4 and they can focus through that, and the machine will come up as +1, or +150, not showing the full prescription that child has. The same thing is on an autorefractor when you go, as an adult, if you go to an eye doctor, if you have a child and they're looking at this autorefractor and they're really focusing hard, you may not get a correct reading. That's why it's always good to be evaluated with something called retinoscopy, where you can really get a better idea of, is this the correct prescription that I'm finding for this child or for this adult?
That's a really good explanation. I also think that we should keep in mind that whatever you do as a parent, if you are worried about something, don't just say, okay, the doctor said everything's fine. Get that opinion.
Right, absolutely. Absolutely.
Right? Get a full exam. I always say, this is just a screen. You were worried about something. Let's get it checked out.
That's exactly right. And definitely, definitely by the age of 3. And if obviously, if you're worried before the age of 3, you should get it checked out. But definitely by the age of 3, all children should really have a full eye examination. And seeing a pediatric ophthalmologist or optometrist, pediatric optometrist, I think is a better way to go for parents, because the offices are geared more for very young children. Once a child is older and then they can sit and they can read the letters, that's okay. But for very young children, sometimes we can put cartoons on, keep them busy, give them a toy to look at, keep their attention going so that we can really kind of figure out what's happening with their vision.
Right, and also understand all the developmental things like amblyopia that can happen in that age.
Of course, absolutely. And it's not even only that, tracking has a lot to do with reading. When we read, we're looking at word. If a child has trouble doing that, they're going to have trouble in school. So, looking at ocular motility, not only looking at the prescription, how does this child, how are their eye movements? Is there a hidden eye turn? There's something called a microtropia. Sometimes one eye turns in just a little bit, and you can't really see that until you evaluate the eyes with certain tests, like a pupillary, a pupillary Purkinje image. So that's really, being seen in a full eye examination would really bring out those things.
Oh, wow. You know what I get asked every once in a while by parents? My child's pupils are not the same size.
So that's very common. Obviously, as a pediatrician, that can be a big problem if there's something major going on. I would say most people do not have, within a millimeter, maybe 1.5 millimeters, that could be considered normal. Beyond that, there might be a cause for concern, so, and what else is it associated with, right? There's Horner syndrome, where you have ptosis and a meiosis. So, that signals that something else might be happening in their chest, obviously. So it is a cause for concern, but when it's a great disparity between the two eyes.
Right. I think there are parents who are staring really closely. And maybe one dilates the other.
Right, that's right.
but again, like if a parent is concerned, they want to see an eye doctor, it's a great idea, I think. Okay.
100%.
I want to talk about vision training, please.
Sure. So vision training, and this is more of a controversial subject. I had vision training as a child. Even though I don't do vision training, I do believe it does have usefulness in the right person. There's actually a lady in my shul. She's in her 70s and she's going for vision training because she has she had TBI, she had a traumatic brain injury, and her eyes are not focusing together, and she's going through vision therapy and it's helping her. Vision therapy really works on helping the person to use their ocular muscles better, more in sync, more in coordination with each other. Again, if there's an eye turn, many people feel in the eye care field, before going through surgery, maybe we could train the muscles to work a little bit better. That's, that's something else to look into. I think it depends on how bad the eye turn is, how often the eye turn is, and what other conditions might be behind all of that.
Right. I'm going to give a medical disclaimer right now. Okay, medical disclaimer is we're not here to provide medical advice.
Right,
These
right.
sound like something that could be, a cause of conflict, right? Maybe the ophthalmologic surgeon will say it's time to operate,
exactly
and then the optometrist will say, no, we need to do more vision training.
Exactly. Or it depends,
for information purposes. That's it.
Right. Actually, I work with a woman, and her daughter had a hypertropia. And she came to me asking what she should do. And her daughter was walking around like this because her two eyes were not working together properly. And I told her that I think you should get surgery because a hypertropia is not usually helped with vision therapy. That's a harder type of eye muscle to help. So there are many optometrists like myself that would refer patients, to a surgeon. Another example is I saw a young man in his 20s. Who is observant, who has a nystagmus and an eye turn, and he was having problems meeting a shidduch because when he would go on a date, he would have to turn his head. When people have nystagmus, they have a null point where the eyes stop moving in a certain position. So his null point happened to be when he turned his head to the left. Right. And every time he was meeting someone, he had to turn his head in order to speak to them. And obviously the young women were not very happy with this. And I referred him to an ophthalmologist who is a big strabismus surgeon in New York City. And now he's straight. And it's very nice. It's very nice. And we're helping him to drive. He has impaired vision, but in New York City, you can drive with 2100 vision. So I fit him with telescopes, and we're helping him to drive as well.
Oh, so, wow.
Yeah. So it's a nice, it's a nice story. It's a nice story. But so it's not such a clear cut, optometrists don't like surgeons don't like, we work together. It has to be the right patient for the right type of procedure, obviously.
Right. Can you tell me more about vision training? Because we talked about it just so briefly. I want to know, what is it used for? What evidence do we know is out there?
Sure. So, and again, I wouldn't consider myself the expert on this, but so vision training, vision therapy are when usually optometrists, although ophthalmologists do vision training as well. It's called orthoptics, and we train the eye muscles to work better together. For instance, if somebody's eyes can't turn in, we'll give them eye exercise to try and strengthen the muscles so that they can turn in better. If somebody has an eye that turns out, or that turns in, maybe we want to give them eye exercises to straighten the eye so that the eye will turn straight. For instance, there's something called a Brock string, which is a long string and it has different beads on it. And you have to focus on the different beads as they get closer and closer to your nose. That's strengthening the muscles to look in. There's something else called vectograms, where it's a double image where you pull the vectograms apart and you try and keep them single as long as you can. Again, trying to strengthen the muscles in that sense. You may have seen boards where there are different lights that shine on the sides. That's eye exercises that are strengthening eye movements to the left or to the right, again, so that the eyes are moving in sync.
But what
There's
problems would this be used for?
So in vision therapy, anytime that someone has, again, either an eye turn or aphoria, where the eyes are not working together properly, that's basically, again, a cross eye, wool eye. Anytime if the focusing mechanism is not working together, not working properly, if a child has trouble focusing from their paper to the board and back, that's also another eye muscle, the focusing muscle that's being, that has to be strengthened.
What about kids with learning disabilities?
So that's a whole nother topic. That again, there are techniques to help kids with learning disabilities, and that involves more like eye-hand coordination. Again, that's really out of my realm, that I don't really do very much. I apologize on that.
Right. I mean, I can get somebody who does vision training, hopefully down the road. I will say, though, that from my understanding, we're not talking such evidence-based here. Like if you're looking for convergence insufficiency,
Right.
I think that has a better
Right.
shot. But I think sometimes people want like a simple answer to a complex solution. If a child has dyslexia,
Right.
it's not necessarily because they have a convergence insufficiency.
Right, I agree 100%. Although it's interesting, I mean, if you do look at the literature, many kids that have learning disabilities also have binocular problems. So that's, so while it may not solve the whole problem, it might help.
Right, it could be a piece of it. Just be careful when somebody tells you, if you just do this, it will go away.
Right, 100%.
Don't expect the magic cure here.
100%.
I should at some point interview somebody on this topic, because I know it's a topic of interest. And speaking of topics of interest, I want to talk about prism glasses, please.
Sure. So prism glasses. So prism glasses are used for many different reasons. We spoke about the person that has trouble turning their muscles in. A prism, again, is a lens that moves the image of an object to a different position. So if I put a prism in front of my eye and I'm looking at you, the image of you is going to move to a different spot. If a person has an eye turn, if their eye is turning in and they can't look straight, I'm going to put a prism so that the image moves to where the eye is. Then the eye can turn straight and they can see what they're looking at without having to, to have a cross eye. So the prism actually moves the image to where the eye is. We use prism for other things as well. At the Lighthouse, I see patients that have strokes. They may have a hemianopsia where they're missing half their vision, or they may have loss of peripheral vision. So in those cases, we use a prism to move the image of the object into where their vision is. So in a hemianopsia, if somebody has a right hemianopsia, I'll do it on your side. If they have a right hemianopsia, I'm going to use a prism that moves the image of everything on the right side to their left side so that they can see that.
Like sliding the vision screen over. Just
That's
slide
right.
it
That's
over.
exactly
Wow.
right. That's exactly
so cool.
right. Yeah. Yeah. If they're missing their peripheral vision, we do the same thing. We have prism that moves whatever's in their periphery into the center of their vision. Sometimes a new technique that's being done is for children with autism. And again, this is not so much published in the literature. This is a newer thing. We're just giving many children with autism, they tend to have a posture where they're more focused down. By giving them prism that brings the world up to them, sometimes it brings their gaze up as well. So if I give them base down prism and it moves their world up, maybe it might move their sight up as well.
Well, wait, why are they looking down to begin with? Are they intentionally looking down to limit the visual input?
Sometimes. Sometimes, yes. And again, I'm not an expert on this. I
Mhm.
was just reading some papers on that.
Interesting.
But yeah, but many kids that do have autism tend not to look up. Maybe they don't want to, I know gaze sometimes is hard to
Mm.
meet another person's gaze. Um, and this again is more experimental. If somebody has double vision, again, we're using a prism to slide over the image so that the person does not see double.
Wow.
And that can be vertical or horizontal or sometimes both. Another use of prism, sometimes people have something called macular degeneration. And so macular degeneration is when there's a blank spot in the middle of their vision. And people sometimes learn on their own that they have to turn their head in order to be able to use a different part of their vision to get around that blank spot in the middle of their vision. But sometimes it's really hard for people to understand that. So we put a prism in front of them that moves the image to a different part of their retina so that again, that they can get a little bit better vision without actually having to turn their head or their eye.
That's amazing. I didn't know any of this. This is so cool. Who prescribes these prism glasses?
So I prescribe many times
Mhm.
these types of prism. For children with binocular problems, that's more of a orthoptist or optometrist that specializes in vision therapy. But, just in terms of ocular pathology, hemianopsia, stroke, again, it's called eccentric viewing, prism. I do a lot of that at Lighthouse Guild.
So it'd be primarily the optometrist.
Mostly, yes. Yes. I'm trying to think. There are, yeah, I would think mostly optometrists. Yeah. Sometimes you might see a neuro-ophthalmologist who works with prism as well.
Interesting.
They
Very
work with prism
interesting.
as well. Yeah.
So I want to talk more about other things you have to help accommodate low vision.
Sure. So we do have very strong spectacles. Sometimes anytime you bring an object closer, it becomes magnified. So strong reading spectacles sometimes are very helpful for patients. Hand and stand magnifiers sometimes are helpful. But honestly, today, people are using their phones for everything, right? So if I turn on my phone and if I open up an email like that, and then I just swipe down on my phone.
New York State Optometric Association, address to Dr.
So our phones are doing many things for us. There's even a magnifier on the phone. But there are electronic magnifiers as well that can magnify a paper in front of you or magnify a screen in front of you. There are applications on tablets that children use where they can attach the tablet to a smart board, and then they can see the smart board where they're sitting instead of having to view it very far away. Glare sometimes is a very big problem for people. There are conditions called rod monochromatism or achromatopsia or rod cone dystrophy, where people are very, very sensitive to glare. Even inside, even where I'm sitting might be too much for them. So certain tints are very helpful as well. And sometimes very necessary to help people manage better or children manage better as well. So we have telescopes, which are like little binoculars that, again, this other young man that I was telling you about was able to drive with. And those are like little binoculars that are put on glasses. So there's a whole host of devices. We have a whole new technology department where there's actually a great device from Israel, yay Israel, that came. It's called the OrCam. It's a little camera on the side of a pair of glasses. It takes a picture of what you're trying to read, and then it will read to you whatever you look at.
Oh, that's so cool. Do
It
people still
also
use Braille?
People do use Braille. Children are still taught Braille in school. if their vision is at a certain level. And that's up to if a child is visually impaired, they're assigned a teacher that's called the teacher of vision impairment. And it's really up to that teacher whether they decide to teach them Braille or not. And they do teach Braille, but honestly, because of the way the world is right now, except on Shabbos, when we can't use anything, very few people use Braille today because everything is text to speech, or, usually if you can't see the print, if you can't make it large enough or dark enough or black enough to see, then you're listening to it, and that brings up a whole nother host of how do we learn? We're visual learners. Can we learn, by auditory means? So that's a whole nother avenue.
Absolutely. What about people who later in life are losing their vision?
So it's always a discussion. Children suffer too. Children really, vision loss is very isolating for anybody. And children definitely suffer as well. But people that are older, obviously, sometimes it can be a greater challenge to adapt. That's why going through programs at Lighthouse Guild where we can teach a person how to manage better with their vision loss, through rehabilitation, through something called mobility training, or through adaptive technology, being able to learn to use a computer better, or through even teaching to cook, prepare food. There's something that fits into a cup that starts beeping when the level of liquid gets too high. So working with people to use their vision to the maximum that they can with these different devices really enhances their life, and makes it so much easier to function and manage.
That makes a lot of sense. What about the white cane?
So the white cane is still in use.
There's a great piece, I'm sorry, but there's a great piece in the Jewish press, White Cane Awareness. I was just reading this.
Very good. I'm so happy. I would love to have a copy of that. I have to look that up. That's great.
Yeah. I don't know if it's online or not. I'll have to get you a copy of this.
I would appreciate it. Yeah.
So this is by it was written by one of the authors, but it's about the person who started Insight to Eyesight. What is it name?
Oh, yes.
Rachel
Bodek.
What is the name of this organization? Insight into Eyesight?
Yes, that's the name. That is the name, yes.
And that is a great resource for families.
Yes.
With vision issues in their
family.
Yes,
good for her. She's a wonderful person. Yes.
I'm looking for the second part of it, which has all that information, page 33. And so that was, I read that article, and she was talking more about the use of the white cane.
Right. Rachel is, she's an amazing person. When you first have to tell a patient that a mobility cane may be helpful for them, sometimes it's a very hard conversation to have with people, because people just associate the white cane with blindness. And most of the people that you see with using a white cane are not fully blind. They actually have vision, but the white cane helps them to use their vision better. And the way it does that is obviously, so some people just have vision centrally, right? At end-stage glaucoma and end-stage retinitis pigmentosa, people have just tunnel vision, and they can't see anything on the floor, or they can't see around them. So if you're using a white cane, it alerts you if something is in front of you that you won't be able to see, or it alerts you if there's somebody on the side of you that you can't see as well. Sometimes depth is difficult. Going up and down curbs or steps might be really hard. They're not black and white, they're shades of gray. So using the mobility cane to go up and down a curb or a step to feel how high or how low the curb or the step is really helpful so that you don't fall. But unfortunately, it just has this really bad connotation that if I use this white cane, I'm blind. And again, that's really not the case. Most people have some form of vision that they're using. It's just the cane is helping them to use their vision better.
Right. Rachel called it her frenemy.
That's right. That's a great, some people say, right, it's their companion, it's their, right, yeah, but I
It's a
like that.
love-hate relationship, right?
It is for
Right.
sure.
Right.
It
I
is
wonder
for
if also, I mean,
sure.
it also alerts other people around them.
That's right. And it's very helpful, like in a bus station or a train station, or an airport. I have a lot of young people that I see that are visually impaired, and they go up and they say, "I'm sorry, what time is the flight leaving?" And the person looks at them, "Well, it's right there. Why can't you see it?" So people don't realize there's no big sign on a person
Right.
saying, "I'm visually impaired." But if they see a white cane, then they know this person can't see, or even crossing a street. Why didn't you see that my car was coming? Well, if I see the white cane, I know maybe you don't see me.
Right.
So
Right.
it definitely does
Right.
alert other people.
Right. Her organization, I'm gonna get it right, is Insight Beyond Eyesight.
Right.
So
And
people
they,
can reach out to that.
yes, they're wonderful. And they actually have a lot of programs for children as well, where they have social events. Again, we spoke about how isolating it can be sometimes for children. Sometimes getting to know other kids that have vision impairment is really important.
Right. And for parents to have support and resources.
Right, 100%,
So
100%.
I think that's. Anything else you want to add? This has been a lot.
Yeah. No, I mean, it's my pleasure.
Yeah.
I think we really covered most of what I think we wanted to, which is great.
To the intro, right? This is the intro because there's more.
You're making me work, Dr. Ming.
But I want to thank you so much for doing this with me. I really appreciate it.
My pleasure. My pleasure. It's an honor meeting you, and
You're so sweet. Mine to meet you.
Thanks for listening to the JOMA Preventative Health Podcast. If you've enjoyed this, please rate and review us on Apple Podcasts and share this with your friends. For more information, check out our Instagram at JOMA_org. Check out our website, www.joma.org, that's JOWMA.org, or email us at health@joma.org.